Hey, it's Chris Bowling.
It's Chris Byer.
We have two guests today, Kevin Schoen
Yes.
and Jared. Thank you both for joining us.
Good
So,
morning.
morning. So, Kevin, you and I started a relationship about 6 years ago. We were struggling with pharmacy cost on our commercial health plans, and you had purchased a pharmacy just right down the road from our office, who was one of my clients. And boy, did I learn what I did not know about pharmacy. And
Been a
you have
journey.
been so helpful over the past 6 years, helping ourselves and our clients get this horrible thing called pharmacy spend under control. And through that, you had thrown out a term, 340B, which I had never heard of. So why don't you tell us about PrimeCare? What's 340B, and all of the amazing partnerships you have formed since our first engagement together?
You bet. No, thank you. Really, kind of on a national scale, a few of us healthcare rookies got together in 1994 just to deal with, reimbursement, the new thing called managed care back then. Everybody was pretty fearful of what that meant to their revenue. And then even about 20 years later, when we started to get involved with ownership of a small pharmacy chain, starting to understand what 340B was, just on the periphery. And it was really a basic understanding, which I think is what, anybody that has some affiliation in pharmacy or with the health system has. But a few years ago, I met Jared, and just in terms of understanding the full scope and intent of the program from someone with that specific industry experience, it was a total game changer. Literally a beacon of light to a health system, to a pharmacy in the right manner. And really it cuts into the costs for the entire community if it's run properly.
Yeah, that's a great overview, and no different than the first time I heard it. It still didn't make sense to me. So Jared, tell us about what is the 340B program? How did it actually originate? And you have helped many of our critical access hospitals actually better optimize a 340B. So if you'd be so kind to elaborate.
Sure. So 340B was started in the 90s. It's a government mandated, not government funded drug discount program. So it was designed to stretch scarce federal funds for all these entities. And when I say entities, that means your critical access hospitals, your high Medicaid percentage hospitals, and your federally qualified health centers. They all qualify for this program, and they qualify for deeply discounted drugs. So the program states that in order for an entity or a drug manufacturer to qualify for Medicare, Medicaid formulary, they have to offer a 340B discount. So therefore, all your brand drugs have 340B discounts, anywhere from 35 to 99.9% discounts. The discounts have gotten deeper because the Affordable Care Act had a clause in it that if our manufacturers increase their price by more than the standard inflation rate, which up until the last 2 years, inflation was pretty steady and low, they had to discount their drugs even more. So therefore, you have some penny price drugs because of the price increases that Chris, all your employers are seeing, these sky high insulin prices and different things. So Kevin and I were brought together just by happenstance more than anything else, and then it's flourished from there into PrimeCare 340B and all the different things we have, and then meeting you guys and being able to capitalize on these critical access hospitals drug programs and helping them really maximize the program first off with their existing setup, but then also leveraging that into their own employer benefits packages, and then also becoming the medical destination in their community. Like all these rural hospitals are struggling financially. So that's my biggest goal is partnering with guys like you, where you can do direct contracting because the most infuriating thing for me is when I sit down with a CFO or CEO of a rural hospital and they're like, well, we're at the mercy of the Blues. Why are you at the mercy of the Blues? Why are you not rewriting the playbook so they're at the mercy, your mercy, not the other way around? Like let's partner with the employers in the market and figure this thing out instead of just taking what Blue Cross gives you or United gives you.
Yeah.
So
No, that's really well said. I know we've introduced you guys both to some federally qualified health centers. Some of those are our clients. Some of those are just employers in our community. A lot of our rural hospitals, just like you said, to understand how their program's working, figure out if it could be better. And then that next step is figuring out how to tie that in with the employer plans to make that a destination. It's been great for all parties.
Yeah.
So Jared and Kevin, if you've talked to a hospital or a clinic client in the past, and they say, we've done 340B for quite a long time, we don't need any help, we're doing it all well. What do you say to that? Because, you know, your job is to help them find ways to be better, but is anybody doing it right without having that full analysis?
3 years ago, 100%. Like, you had hospitals out there doing a great job, but the rules have changed over the last 3 years. So anybody you talk to in 340B today are going to use even more acronyms than we're used to in healthcare. And you guys know that, like, we're acronym driven as a business, but you've got ESP, you've got all these manufacturer rules. So the game has changed dramatically. And I tell everybody, I do free analysis all day long. My wife gets mad at me because I work for free a lot, because I look at these hospitals and I'm like, give me 10 minutes to look at your program. Let's see if there's holes there, if there's opportunities. It doesn't cost you a dime for us to look at it. So when we do that, we look at their existing setup, and then we start asking questions and partnering with you guys on, are you self-insured? Are you utilizing your discounts appropriately for your own employees? How are you minimizing impact of MAP and PAP and some of the other stuff that's going on in the marketplace that we all know is, that game is changing too, just like 340B has changed. The manufacturers are not stupid. Like, they have a team, as you guys know, that are always trying to figure out how to make more money because they have shareholders to report to. So we have to have a team with our hospitals to try to figure out how to offset some of those impacts.
Yeah. So
And a lot of that, Chris, too, a lot of that is driven by the lack, of job availability in that space. So, tight job market, less chance to attract talent for that specific program. And so that's where, we kind of fill that gap for the facilities.
So one of the things we've been discussing is, obviously we are really concerned about the specialty meds, right? Because those are the ones that are the really high cost drugs. And what we've identified is, a lot of our hospital clients, they have, they're self-funded, and they have a prescription benefit manager that's managing their drug formulary, helping to auto-adjudicate claims when they're going through a pharmacy. The problem is that we know that the specialty meds is where the hospital can make some revenue if they're running through their 340B. But the problem is the PBM says you have to use our specialty med pharmacy, and therefore all those drugs are not running through the 340B. They're running through the PBM, and now the PBM's getting the rebates. How do you optimize that model? How do you change that script? So then that hospital can figure out how to get back into that profit model when an employee or an employer's employee has to fill that script.
I have this conversation all the time, Chris, and what I tell everybody is the first question so most of your PBMs will say, oh, we do 340B, we help you guys with that. But when you really start asking the hard questions, they're doing the Caremark, all the PBMs are doing the same thing. They have specialty locks because of what you just described. So they're going to drive that business to their specialty pharmacies. And then I start asking questions about, let's talk about specialty, because a lot of these employers think, okay, Humira is a specialty drug. Well, is it really? Because it's not limited distribution. Your normal retail pharmacies can dispense that drug. So let's partner with your contract pharmacies that you have in town, bring that business back in locally to help not only your locally independently owned pharmacy, but also you as a hospital, and then ultimately your employees. Humira, everybody knows that it's an $8,000 a month drug. It is literally pennies on the 340B program. So the hospital can do zero out of pocket for their employees, drive that business back into their local pharmacy, pay that pharmacy a fair dispense fee, and then everybody wins. And all of a sudden their employees are not paying stupid out of pocket costs for specialty drugs, and then work with you guys on plan design so it doesn't impact their maximum out of pocket every year and different things like that, to where it's a win-win-win all the way across the board. And then the second step of that, Chris, is to mirror that same program and take it out to the other employers in the market, to where that hospital does control reimbursement and does become the medical destination in their geographic area, to where employers are driving their employees into that hospital for those services.
Yeah. Well, unfortunately, we are out of time, but how is the best way for somebody to get a hold of you guys to help figure out how do they optimize their 340B program? Is it a website? Is it a phone number? If you want to provide that, that would be great.
Yeah, we can post that up, and it's just primecareamerica.com.
Perfect.
Excellent. We'll put that in our video post. But Jared, Kevin, thanks for joining us today. Good stuff as always.
Thank
Thank
you.
you, gentlemen.
All right, thanks, guys.
Yes, thanks for all that you do.